So good morning, and welcome to the launch of Doctors Helping Doctors Transform Healthcare. To all of you who have joined us on the web, or in your offices across the country, and those of you who are listening to us by archive, as well as all of you in the room, welcome. We have a terrific program today. We're going to start with a little bit of discussion about Doctors Helping Doctors Transform Healthcare. From our physician founders who put together this idea and have moved it forward. That will be followed by remarks from our national coordinator, Farzad Mostashari. Then we'll hear from a panel of physicians across a range of specialties in a diverse range of settings in our country who have truly transformed care, improved the quality, safety, and efficiency of care using health IT. And then we're pleased to have Dr. Richard Barron also join us to talk about some of the work that they're doing, particularly around supporting primary care over at the Centers for Medicare and Medicaid Services. We'll break for lunch, and at that point, for those of you on our webcast, we'll cut the live web stream, and then we'll begin an interactive dialogue around strategies to improve the quality, safety, and health care using health information technology. But let's get to the program. It's my great pleasure to introduce to you the chair of doctors, our first chair of Doctors Helping Doctors Transform Healthcare, Dr. Peter Bash. I've known Peter a long time. He practices, and he'll tell you a little bit more about his background, but has been practicing general internal medicine for quite a long time here in the Washington, D.C. area in a small physician practice, and really is an early adopter of health IT, electronic health records, and e-prescribing. He also serves as the medical director for ambulatory EHR and health IT policy at MedStar Health, which is a large health system here in the Baltimore, Washington corridor. He's been very active in the policy arena, and he is going to say a little bit about what we're doing. And so please join me in welcoming Dr. Peter Bash.
Thank you, Janet. Thank you for the kind introduction and not actually mentioning how many years I have been practicing, because I'm feeling every single one of them now. I also want to extend a warm welcome to all of you who have joined us today in the room and on our live webcast. Today we are here to hear the stories and recognize the leadership of several physicians across the country who are transforming healthcare through the use of health IT. We're also here to celebrate the launch of a new nonprofit collaborative effort, which is designed to support this transformation in physician practices and institutions across the country. Doctors Helping Doctors Transform Healthcare is a social media effort that brings physicians together to share their insights and experiences through videos, audio programs, stories, and blogs about why they decided to adopt health IT, the challenges they face, the strategies they use to overcome these challenges, and the impact that this has had on their practices, their organizations, and most importantly, their patients. We're going to talk more about Doctors Helping Doctors, its drivers, its purpose, but before we do, I want to take a moment to recognize this clinician-led nonprofit organizations who have agreed to collaborate with us on this endeavor: the American College of Cardiology, the American College of Physicians, the Association of Medical Directors of Information Systems, or AMDIS, and the American Society of Clinical Oncology have agreed to formally collaborate with us. In addition, individuals from the American Academy of Family Physicians and the AMA have agreed to serve in an advisory role, and we are grateful for that support. All will provide input and guidance to our work, identify physicians who can share their experiences and insights, and identify helpful informational resources that can be brought to bear during this time of transition. I also want to recognize the organizations that have helped make this endeavor possible through their unrestricted grant support. We are very grateful to Dr. Patrick Soon-Shiong, Chairman of the Chan Soon-Shiong Family Foundation, John Glasser, President and CEO of Siemens Health Services, and Dr. Mark Overhage, who is here with us today, and the Optum Institute for Sustainable Health, Carol Simon, its director, Andy Slavitt, the CEO of Optum Insight, and Dr. Joe Heyman, also here today, who chairs the Physician Advisory Board for that organization. Finally, I'd like to thank Boston Medical Communications and Terry Primack for his terrific work on the videos, and A+ Government Solutions, and Speyer and Eduardo Marquez, along with their web team, for developing our website. Thank you all very much.
So now we're going to move into a little bit about why we got started. This was an idea that a number of us had several years ago. And 3 physician leaders in particular were instrumental in the formation of Doctors Helping Doctors, Transform Healthcare, and they're up here today. In addition to Peter Bash, who we've just heard from, Dr. Bill Bria, who is next on the right of Peter, on your left, for those that are watching, is the Chief Medical Information Officer at Shriners Hospitals for Children, and also the founding president and one of the founders of AMDIS, which Peter talked about. And to Dr. Bria's right, we've got Dr. Michael Zarukian, who is the Chief Medical Information Officer and Professor of Medicine at Michigan State University, and also Medical Director in Clinical Informatics and Care Transformation at Sparrow Health System. Those two also serve as founders for this effort. We're going to spend, looking at my watch, the next 20 minutes or so sharing some of the reasons why we got started, the drivers of the efforts, the problems that these physicians are trying to solve, what we'll do, and our goals for the coming year. So let's start, if we could, with Dr. Bash. Dr. Bash, could you share with those who are joining us here today your vision for this effort, how your experiences led to your interest in helping other doctors drive transformation in their practices and organizations using health IT?
Sure. Well, thank you, Janet. And let me start with the second part of your question first. Like my colleagues at the table, Drs. Bria and Zarukian, I'm a practicing physician. The first 15 years of my professional life were spent in a very small practice right here in Washington using paper records, and the next 15 also in Washington in a somewhat larger practice setting, but as part of the health system. And like my colleagues, I'm an early adopter of health IT, the first physician in my health system to use an electronic health record, perhaps the first outside of the VA in Washington to use one, and I believe the first person in Washington to use electronic prescribing. During these many years, I've also worked, as Janet has mentioned, on technology and policy aspects of health IT, and while all critically important, I've come to believe that my most valuable learnings and thus also contributions have come from using health IT in the practice setting. Some of these learnings have come from colleagues, some from participation in research, some from writing papers, but some from patients. Let me relate an actual story. Many years ago, when we first adopted EHRs in my practice, I resisted putting computers in exam rooms as I was worried about violating what I had been trained not to do, which is don't lose eye contact with patients. And there wasn't a body of literature about how to avoid that back then. And I remember in the first week profusely apologizing to one of my diabetic patients about staring at the computer screen too long because I was trying to actually see something I had never seen before, trending of her blood sugars. And during my apology for staring at the screen, I'm so sorry, this is all new to me, she said, "Don't worry about it, Doc. By the way, if you think you were making eye contact with me before, you weren't. You usually had your head buried in the chart or you were yelling out the door for something that was missing. But a piece of advice for you. What you are staring at is actually pretty interesting to me as well. So maybe if you could just angle the screen a bit and move your head, we could both learn something." Of course, we all know now, or should, about how best to use technology in exam rooms such that we optimize information sharing with patients, improving quality, safety, and patient engagement, and thus turning a perceived weakness into a tool for improving care. Other key learnings have come from studying top performers in our health system. For example, we have many docs with same devices, same networking, same software as their colleagues with less stellar performance. So what were they doing differently? In this case, the answer turned out to be primarily workflow, a laser-like focus on outcomes and consistent use of successful processes. I came to understand that even using EHRs that were less than perfect, caring and thoughtful doctors could rapidly and dramatically improve their quality and safety. In fact, I believe it's possible to make care better and safer and more affordable. It's not possible without using health IT combined with change or transform workflow. A pair that may sound forced, but are indeed the basis for what I have seen in most studies that demonstrate the value of health IT. That is the pairing of technology and transform workflow. This pairing becomes sustainable and become two components of a virtuous improvement cycle when combined with a third element, that of payment reform, something that Dr. Richard Barron of the Center for CMMI will address later this morning. And to the first part of your question, Janet, what is my vision for our effort? I am grateful for the legislative attention that Health IT received in the HITECH Act and for the rapidly accelerated adoption of health IT spurred on by the financial incentives and the fear of penalties under the Meaningful Use program. But I believe that practicing doctors need to continue to be at the forefront of this effort. Health IT is an enabler. It is not a solution in and of itself. I believe there is an important role for government, and without this public-private partnership, physician adoption would be much slower and our electronic records would be of lesser quality. But how to proceed to optimize electronic health records so that they realize their full potential, and equally important, how to transform care processes to take full advantage of these new technologies, that is something that should come from us. All of us in the room, all of us on the web. From docs in solo practices in rural America to doctors in academic centers in big cities. My ask of my colleagues, join us. Our voices, our experiences, and most importantly, our center, which is keeping the focus of what we are doing on the patient, is sorely needed. Doctors Helping Doctors seeks to build a community of physicians who will constructively and collaboratively share their insights and experiences in their own words across specialties, across practices large and small, across institutions, small community hospitals, and small and solo practices to help each other make this transition. So I thank you all for joining us in this effort.
Thank you, Dr. Bash. Dr. Zarukian, if we could go to you. You have had such a rich history spanning academia, hospitals and health systems, and organizations that are on the ground helping physicians make this transition. You've seen a lot over the last several years. Can you share with all of us who are watching today your perspectives on what's happening in the field right now? What are the challenges and opportunities? And maybe a little bit about how Doctors Helping Doctors can help to address those challenges.
Sure, thank you, and thank you all for coming and for participating in the webinar for those of you who are online. What I see happening is an increasing recognition by physicians, not only across the country, but across various specialties, that the healthcare system is changing in a tangible and palpable way, that their payments and that their reputations will be increasingly based on objective data that demonstrate that the quality of care they deliver is high and that the value that it provides to their own practices, to their patients, and to society is significant. They also increasingly recognize that to achieve the healthcare transformation that is incorporated in moving from volume of care and complexity of services to one that values outcomes and quality more requires better information tools and tools that are available in real time for care and for collaboration. They have an increasing sense that health information technology and EHR systems can help. They recognize that there is time-limited funding to help them with the difficult process of change that is required to move from paper-based systems to electronic systems, or even in moving from electronic systems to systems that fully support the information management needs that physicians have and the collaboration tools that they need to provide excellent care. They are also increasingly able to see the meaning in the meaningful use regulations for their own specialty and have good experiences to help drive the evolution of that so that the use of EHRs and other health IT in meaningful ways becomes easier, becomes more impactful, and helps to achieve the national goals for quality and value. The other side of that, however, though, is that they also recognize increasingly that to do this and to do this well, they need more help. They need help planning, implementing, optimizing, and realizing the value from their investment. These represent some of the challenges that they see. They know that implementing and optimizing an EHR or other health IT is still hard work, and that making that easier is both a work in progress and one that is benefited from by reaching out to their professional societies, reaching out to their physician colleagues, and reaching out to others in the healthcare information technology industry for some of the best practices to get there. They realize that they're doing it even today in a system where there are still perverse incentives with regard to some of these quality emphases. That is changing, but it is still a work in progress in that regard. However, they see that one of the outcomes of the transition enabled by ERA and HITECH is the preparedness, if you will, to hold providers and systems accountable for evidence of quality as demonstrated in objective terms. So they need help getting started for some, they need help optimizing for others, or they need to hear some best practices from their colleagues with regard to what works, what doesn't work, and how to take next steps in that regard. So one of the ways that the opportunities for doctors helping doctors to assist with that process is to create that conversation, the social media connection between physicians who are on this journey towards healthcare transformation that's powered by information technology, to hear how some combination of EHR implementation, workflow redesign, and best practices can help lead to some of the benefits that, for example, I've seen in my own internal medicine practice, in which we were able to demonstrate a $63,000 hard dollar per FTE physician financial benefit from fixing our broken workflow processes and paper records and implementing EHR system and incorporating practice redesign in a way that helped us provide higher quality at lower internal costs, and also to improve access to patients. So we had, for the first time, an open access policy that was empowered by moving from paper charts where our heads were buried to an electronic health record system and other HIT that gave us all the information we needed to comfortably cross-cover for each other on a moment's notice for almost any problem a patient would have. And the patient satisfaction was strong enough that we decreased our cardiac stress tests simply on the basis of if you survived the surprise that you could actually be seen today instead of later, we knew you must not have coronary disease. So I'll just close by saying Doctors Helping Doctors is about telling those kinds of stories, about helping to identify what are some of the best practices, what are the pitfalls to avoid, how can we share our understanding of approaches, how can we help shine a light, if you will, on what it takes to be able to take the powerful opportunities that we have to improve quality and value, which is why we went into medicine in the first place, keep our focus on what's best for the patient, to make sure that their needs come first and matter most, and to use our technology and our experience to help transform care.
Thank you. Dr. Bria, as co-founder of AMDUS, you have had a long history, rich history of collaborating with other physicians, particularly CMIOs. Can you share some of your insights around what we're doing here and the role of the organization?
Sure can, Janet. Thanks very much. You know, folks, there's no question that we're living in tumultuous times. The idea of our profession being in a inflection point in how we're perceived, how we're allowed to do what we think we really should be doing on a day-to-day basis, the care of our fellow man, the way in which the complexity of what we do has increased markedly, and the idea of the tools that we have to achieve better diagnosis and treatment options certainly are impressive, but yet you talk to colleagues and you start to get more and more stories about being besieged. We're living indeed in tumultuous times. There are few things that we can start to embrace and start to adopt that will get us back to our roots. Our roots have always been the same, the care of our fellow man. There is no question about it. Since Hippocrates, it was so. As it was with my father, who was the first Italian physician in a little town in Connecticut, the idea of being part of a community, being connected to your patients being primarily concerned about their health and well-being is really what we need to refocus on. And that may sound strange in the middle of a discussion about HIT, but in fact, it is exactly the same issue. The idea of our tradition as a profession of being an apprenticeship also is one of the cores of this organization. The idea that we must now reach across the aisle. There are a lot that have adopted. AMDIS has over 2,000 members. That is marvelous. But the reality is the medical profession in this country is much larger and needs a lot more understanding, adoption, and self-help. It is our time to reach across that gap and give each other a hand up. And to do that, I think we have to have compelling reasons to get involved. Perhaps the ones with regards to technology itself is totally inadequate. Perhaps even the incentivization, even though that has been very helpful, but the idea of it being sufficient, probably not in the bigger picture. What is in the bigger picture is this is the way for us to continue to fulfill our core professional responsibility in excellence and demonstrating that in the care of our fellow man, nothing less. So the notion of doctors helping doctors is truly doctors helping each other make this transition. When I tell a story, and it is my favorite one recently, about a Dr. Chris Snyder in Maryland, who with the use of an information system, by simply designing an ordering pathway for patients that are seen in the emergency room, in order to allow them to recognize sepsis early, intervene with the proper and well agreed upon literature care of those patients in the correct timely manner, and hours can matter, in 1 year saving 77 lives that the year before were lost. Now, what physician is going to say, yeah, this is all about the bytes and the bits, Bill, and it's this, no, it's not. No, it's not. No, it's about who we are, who we really are. And from that perspective, even though that's a very dramatic version, the idea of proper tracking of patients with asthma, diabetes, and hypertension and other chronic illnesses in a much more accurate way, most importantly, the idea that America is mobile and the idea of not recognizing that in the tools that we use in order to track when you've gone down to Tampa, Florida, or gone back to New York City, New York, and know where all of that information is. Yeah, we're at a point that if we're really going to serve our core reason to be as a profession, we've got to embrace the new tools. We've done so for millennia. And we've also done, as all of us may know, and it's just a wonderful story if you look at the turn of the century, when Dr. Laennec first took a newspaper, rolled it up, made a tube out of it, and put it next to a patient's chest to create the first stethoscope. What was in the London Times within the next couple of months was how horrible this was. This was distancing the physician from his or her patients. This was an abomination, and these instruments should be removed from the patient care process. Where did you hear that lately? So from the perspective of understanding that, in fact, as our core responsibility as physicians is to that one truth, care of our fellow man, so it is that this is the time to share with each other, to assist each other. There is not just one way through this morass. There are many ways through it, but there is only one way to show its value, and that is in the improvement in the safety and the quality of the care of the people we're charged with providing that care for. It was so when my father started this in Greenwich 60 years ago, and it is today. So we look forward to telling you more about it.
So thank you. And those are the words of our physician founders of Doctors Helping Doctors Transform Healthcare. Thank you for your insights. And if you'll stay up here for our next discussion, for our next physician who's going to be providing some remarks for all of us here as well as all of us who are watching online, I'd like to introduce to you Dr. Farzad Mostashari. He's the National Coordinator for Health Information Technology at the Department of Health and Human Services. And this is the organization that is really helping to lead the way and define methods for moving forward for physicians across the country as well as hospitals in using health IT in a way that improves care, improves quality, safety, and efficiency. And prior to his joining the Office of the National Coordinator in July 2009, he served at the New York City Department of Health and Mental Hygiene as the Assistant Commissioner for the Primary Care Information Project. And I still remember these days when he was pulling together physicians in New York City and helping facilitating the adoption of prevention-oriented health IT by over 1,500 providers in underserved communities. And so this prepares him well for the task at hand in terms of transforming and moving a number of physicians across our country to the use of health IT to improve care, to improve cost, but to result in more prevention and improve the quality and safety of care. So please join me in welcoming Dr. Farzad Mostashari.
Thank you. It's a pleasure to be here. It's a pleasure to be speaking to you all. I'm the administration's National Coordinator for Health Information Technology. Health Information Technology. And for me, that's the right order. It starts with health. It's about improving the care for our patients. It's about better information. It's better to know is the basic concept. When you get that call and there's a patient of yours in the emergency room. I've gotten that call. And I felt the emotion that comes with saying, do I really remember this patient? Do I really remember what their medications are? Am I sure about what happened at their last visit? Am I even sure I'm thinking about the same patient? And at that moment, 2 a.m, sitting up in bed, trying to remember, being able to log into your EHR and pull up that patient's record and send a copy of your last visit note to the emergency room, it's hard to imagine going back. And once you go to an electronic health record, I don't know, it's a one-way process. And that says something. There's lots of innovations that people try and then they go back. Electronic health records seem to be a one-way process. And that, more than anything else, speaks to me volumes about the value of electronic health records. And it's about technology. Technology is the promise of innovation. Technology embodies the idea that you can have it better next year than this year, faster next year than this year, cheaper next year than this year. Uniquely, technology holds that promise. That it can improve, that it can be the spark for innovation, which is, I believe, the most fundamental secret to American success has been innovation. And this has been one area where, frankly, we have lagged. Where for decades, where other countries made progress, we lagged. Where after decades, some of the leaders in this room adopted electronic health records 20 years ago. And it took us 20 years to get to 20% adoption among primary care providers in this country. Even less, 17% among all providers. 20 years to get to 20%. And in the past 2 years, we've added another 20%. We've done in 2 years, in the past 2 years, what it took us 20 years to do before. That acceleration came because of the Health IT Incentive Program in Meaningful Use. When Congress passed the American Recovery and Reinvestment Act, this was the reinvestment part of the Reinvestment Act. This was saying we need to set infrastructure, not only in roadways and railways, but also infrastructure for information in the healthcare system. And as Mike said, there's time-limited funding to help providers make that transition, doctors and hospitals. It also set the foundation for a certification, a competitive, market-based certification of electronic health records that has greatly increased the options available. There are now over 1,000 certified products to choose from. It can be overwhelming, I know. 60% of the companies that build those products have 50 or fewer employees. There's a whole new spark of innovation in this marketplace. I was visiting a solo practitioner in San Francisco, Dr. Gustin Ho, who, like many of you, has been living for the past 20 years in a fee-for-service environment. He gets paid when he sees a patient, when he documents certain elements. And he talked about the transition for him when he decided to adopt an electronic health record. He got help from a regional extension center, a regional health IT extension center, modeled in part on the groundbreaking work in Massachusetts and what Janet talked about, what I did in New York City, giving a helping hand to small practices, particularly primary care practices, who'd struggled in the past to adopt electronic health records. He got a helping hand. He got his system set up, remotely hosted, security aspects implemented, configuration customization done. He made that transition, and it improved his efficiency because he used it to improve his internal efficiency so he could thrive in the fee-for-service environment. He could be more efficient. He could have the information he needed. He could have the right workflow, so he could have 3 rooms going. Or it could be his practice manager, who's his wife. But more than that, he was now part of an IPA that was getting 180% payment from Medicaid because they had collectively reduced hospital admissions for Medicaid. They were applying to be an accountable care organization, a physician ACO, physician-led ACO, because they believed that with the information they had, they could be a virtually integrated delivery network, that they didn't have to be employed by a hospital to coordinate care with a hospital, because they could use the information systems to do that. And on top of their electronic health record, they had worked with a startup from San Mateo to Google index the information in the record so they could type in for a given patient a keyword and pull up all the documents that related to that keyword before. This is an example of what's happening in doctors' offices, small and large, across the country. Primary care providers 2 years ago, it was 20%. Last year, it went to 30%. This year, we released data yesterday that showed it's at 40%. Next year, it's going to be at 50%. And we are past the tipping point, folks. We're past the tipping point. Working on paper is going to increasingly be the exception, not the rule, for medicine, as it should be. I was in Cleveland yesterday, meeting with Dr. Randy Siebel, author of what I think is going to be a landmark study in the New England Journal of Medicine, September this year. What they found in Cleveland was with 27,205 patients with diabetes, 27,000 patients with diabetes. This is not a small study, folks. 27,000 patients with diabetes. Paper-based practices delivered the standard of care that we all learned in the 3rd year of medical school. Check the sugar, check the eyes, give them a pneumonia shot. Basic stuff. Consistency in paper-based practices was lacking. They got those elements of standard of care, for which there's no argument, 7% of the time. 7% of the time. And in the EHR-based practices, it was 51%. Still not good enough, he said. But What gave him hope was the EHR-based practices, after controlling for the patients' ages and their gender and their income and their education and all that, were improving faster. That's what it's about, is when you use it appropriately, when you implement it appropriately, when you optimize, when that tool becomes a tool in your hand, you can improve faster. That's the promise of health information technology. You can improve faster. And all of us want to improve. All of us know that we can improve. All of us learn that in medicine, you're never done learning. There's one thing we learn. It's we always have to be learning. And electronic health records, simply put, help us learn faster, help us learn better. That's why, if you're thinking about adopting an electronic health record, come on in. The water's fine. And yes, there are people who can help you navigate, who can help you select, who can help you optimize the implementation. It is hard. It's not trivial, but there is help. There's the professional societies. There are the regional extension centers. There are the vendors, who, if you choose well, can be a tremendous help in implementing and optimizing. If you're ready, if you've already adopted an electronic health record, my message to you is get to meaningful use. Meaningful use is the distillation of what and how one would use an electronic health record to get to those health and quality and care coordination outcomes. If you think about it, many of you who've adopted an electronic health record that's now been certified are probably most of the way there. It's collecting the basic data, the vitals, the smoking status, the problem list, the med list, the allergies. You already do that. It's having the ability, though, to be the stewards of your own quality. It's having quality measurement done by you, not to you. It's being able to have internally. I was visiting Metro Health, public hospital system in Cleveland yesterday, and they have care coordinators now who have a panel of a couple of hundred patients that they proactively manage. And it's real time. It's not some separate registry. Whenever the patient is diagnosed with diabetes, they end up on that list. The information is on that list, updated in real time. It helps them proactively manage the care of the patients. And they're saving money for their uninsured patients in doing that. And that's the connection. Increasingly, it'll become not only the kind of medicine we want to provide, it'll also become possible not to go broke delivering the kind of medicine we want to provide, that provides health and outcomes and prevents hospitalizations that are unnecessary. That will increasingly be rewarded, as we'll hear about. And once you've adopted an electronic health record, that's where the joy, once you've implemented, once you've optimized, all that work has been done, and now it's time to enjoy what comes next, which is picking something, measuring it, and then improving it. Something, anything. Whatever, whether it's an operational issue, whether it's an internal efficiency, whether it's an outcome, whether it's a HEDIS score, it lets you pick something, measure it, and improve it, and make it better. And work with the whole team with this tool to make you more efficient, higher quality, as a team. And if you've already done that, if you're like folks in this room who've already done that, who've shown that, who've saved the money, who've saved the lives, who've coordinated care, it's time to brag on yourself. And that's what, to me, Docs for Docs is all about. It's about saying, I've used the technology in a truly meaningful way, and I can share, and I can help extend that hand across and say, here's how I did it. And you may not do it exactly the way I did it, but that knowledge, that experience is the most precious asset we have. And I'm so grateful to the providers here on the panel, here in the room, and out there, who are going to be showing that generosity of spirit to not only improve the care that they're delivering, but to share how they've done it and how you can too. Thank you.
Thank you, Farzad. We have a brief transition. If I could call up the physicians that are going to be part of our panel, please.
And while the doctors are coming up, I wanted to share a brief story. I was on call last night, and I got one of those 2 a.m. calls, Farzad. And I think there's also an inflection point in what our patients are expecting of us. This patient was telling me the story of seeing one of my partners earlier in the day and having a reaction to a medication. And rather than guessing or trying to re-describe it, her comment to me was, "You can see my record, doc. You can see what I was in for and what was given to me." I said, "Well, as a matter of fact, I can." Sigh of relief. Now let's move on to the next phase, which is resolving it.
All right, gentlemen, let's step up to the podium. So Doctors Helping Doctors is on. Doctors Helping Doctors is only going to matter if the notion of, when it comes down to the rubber meeting the road, what are we going to do? How are we going to do it? How are we actually going to help each other make this transition? And so I'd like to introduce to you our panel of physicians that have had this kind of a role across the country, and I want to share some experiences and stories with you. First, Dr. Phil Graziano, MD and internist and geriatrician, Hampden County Physician Associates, and President and Chief Executive Officer, Accountable Care Associates, Springfield, Massachusetts. Next, Dr. Brian Jacobs, pediatrician, Children's National Medical Center, Washington, D.C., and CMIO there. Next, Dr. Joe Heyman. Dr. Heyman's an obstetrician and gynecologist in Amesbury, Massachusetts, and a strong advocate for healthcare IT for longer than he and I want to admit. And finally, Dr. Kevin Spencer, the youngest member of our team, I believe. I could be wrong. Emergency physician, a family physician, sorry, a premier family physicians in Austin, Texas. Gentlemen, if you think about what our colleagues that may be seeing this either in real time or subsequently are saying to themselves about, look, we come into the lunchroom, we come into the break room, a colleague's there with his head in his hands, or her head in her hands, and the idea of why do they make us do this? Dr. Mostashari is incredibly eloquent and wonderfully inspiring, but the idea of tolerating and going through this change is a son of a gun. Why should we do this? What do you guys say? Because I know you faced it. I think we all have that have been in this role. What do you say to them in order to make them take their head out of their hands and start to hope. Phil, start.
Well, thank you. And we have a lot of, obviously, the same issues, but when we've made the transition to multiple implementations of health IT, the doc's practice has gotten better. Not at the very beginning, but has definitely gotten better, higher quality, higher satisfaction, and now able to look at some of these new changes in healthcare and payment reform and actually do quite well.
Brian?
Well, thanks, Bill, and thanks for having me today. I think one of the strongest markers of success in the health information technology field is something that Dr. Mostashari mentioned earlier, which is no one's going back. People that move forward in computerized electronic health records don't go back. I've yet to meet somebody who has bought, implemented, and adopted something, used it in an appropriate way, and then decided, hey, I don't like this, I'm going to go back there. So I think one of the most strongest incentives for a physician in terms of reluctance to move forward is go visit one of your colleagues. Go visit one of those 40, 50% of people in your region who have made that move from paper to electronic health records and see what it's like. Can you be efficient? Can you care for patients in an effective way? Can you still deliver the kind of quality care that you want to deliver? And can you still make a decent living doing that? And universally, when we have physicians in our own area here in the DC metropolitan region do that kind of a journey, they come back saying, hey, I want to do this. How do I sign on?
Now, one of the things, Joe, that we have as a gap is people say, yeah, that's great. You got fellows and residents all over the place. They're doing all of this work. You don't have to do anything. Joe, your staff at your office, what's the size of it?
I have one employee, and I've had only one employee since 2001 when I started my practice. I have a solo gynecology practice. I purchased my EMR after getting advice from many people, one of whom was on the board of an EMR company, but she actually suggested that I look at another EMR because at that time, going to this particular EMR that she was sponsoring was so robust as far as the hardware was concerned that I couldn't afford to do it. So I purchased my EMR actually when I was traveling in Washington, D.C. And the way I purchased it was I went to the website of the EMR she suggested. I looked at the pictures, and then I called them up with a credit card and purchased my EMR. And I've been using that same EMR. Of course, it's now much more robust than when I purchased it, and it's one of the more popular ones. And I've been using the same one since 2001.
But why did you listen to that employee?
Well, because one of the things that was most important to me was to be able to go from what was frankly a high overhead, larger GYN practice to a really efficient, low cost practice. And by using an EMR, I was able to avoid hiring billers, coders, people who would find charts which were inevitably missing anyway. And now I've had 10 years of never having to look for a chart, and for higher quality and efficiency within a single practice, a single doctor practice. I can just tell you one quick story about quality. And this was early on. I can't even remember the names of the drugs anymore. But I had a patient come to me for her first visit, and you know, at every first visit, you have to list all their drugs. And this patient told me she was being worked up for some sort of cardiomyopathy. And I'm a gynecologist. I know nothing about cardiac drugs. And as she's listing the drugs and I'm putting them into the EMR, up comes this big red warning that these two drugs together, and I can't even tell you what the names of them are anymore, will cause all kinds of cardiac symptoms. And I was able to just print out that warning for her, hand it to her. She took it to her cardiologist, and that was the end of her problem. So, you know, there's a great example. It has nothing to do with measuring quality or incentives or anything else, but it sure has a lot to do with improving quality and safety for individual patients. I would never go back, never go back.
And that employee is your wife.
My current employee is my wife.
Okay, that's the punchline I was trying to get at. Kevin, what do you say to a colleague that says, you know, yeah, you're doing this, Kevin, but, you know, I don't know. Why should I do this?
Yeah, that's a great question. I mean, I think as a family physician, those are most of the people that will ask me that, and the numbers are going up. The amount of data that we have to manage in primary care and family medicine is enormous. From the consultant's notes to the laboratory data, we're managing the whole patient, the hospitalization, the med list, et cetera. And so really, truthfully, it's very difficult to manage that without health IT resources. So fundamentally, it's better care, but also the sort of the reach you had, where the higher-minded reasons of why we would do this. The patients are now demanding it. They like it. They like it when I can show them their hemoglobin A1C curve in the office. They like to watch their blood pressure trend. They like to email me and access me on our patient portal. We have social media to interact with our patients and do weight loss clinic over tweets and Facebook, and we're engaging people in a way that they want to be engaged and shepherding their health care instead of just waiting for them to access us. So I think it's a consumer-driven market demand that's beginning to happen as well. And then back to running a good business. Frankly, he was able to lower his overhead down to one person. We've expanded our physician group by 50% and not hired one more employee, mostly because the EHR has allowed us the ability to do that. So those are reasons, and we'll hear the pushback, and the pushback is the difficulty of implementation. I would say we can't hide from that, but I would also say it's improving and getting better.
Terrific. Let me stay with you just for a second, Kevin, and bring the question back around. One of the things that that some of our colleagues say is that that I don't want this to change anything. I'm too young, I'm too old, I'm too happy, I'm too sad. I don't want to change anything. We know that that's not realistic, but we do know that for a lot of folks that perhaps haven't spent as much time or investigated as much about this whole domain of applied information technology in the practice of medicine, they can get into trouble. From your experience in leading this in your own environment, what's a question or a couple of questions you say, they really should care more about this as some nice, bright person comes into their office and says, have I got something for you? You need an electronic medical record. What do physicians not ask that they should have asked as these systems are starting to be introduced into our practice?
It's a great question. I think what system that we choose and the vendors we work with and what's happening in your local environment is a very important question to ask. Right now, we're at the adoption phase, but soon, and in some communities it's happening very soon, we're going to be at a phase where we're able to really meaningfully share the data. So you need to see what's happening in your local environment and really ask those questions. There's a larger end game than becoming a nice electronic silo that's really efficient with your data in your own office. There's an end game to really make this meaningful across the entire healthcare continuum, and so I'd begin to pay more attention to that.
Joe, you had another perspective on that as far as HIE or data interchange.
Well, I would agree that health information exchange is extremely important. I think personally, my feeling is that the more popular EMRs will all be able to attach to health information exchanges once they're a reality, which they aren't now. I would echo the thought that anybody who's anticipating doing this, especially nowadays when almost half the people are using EMRs, it's really important to talk to some of those people who are using it and find out what their experiences are with their vendors. To me, it's more important to have a good vendor than it is to have an EMR that does everything exactly the way you want it to do it, because these EMRs, all of them will essentially record the data and store it for you. But to have a vendor who's going to be there when you're in need is extremely, extremely important. And the smaller the practice is, the more important it is.
Thank you. Brian, let me change it up just a little bit. The idea of physicians in practice actually appreciating the data. How am I really doing? Farzad was talking about that, but is that something you found your colleagues really understand or get involved with or ask before they start to adopt?
Well, that's a great question. You know, I've yet to meet a physician who doesn't believe they're optimally delivering care in a paper-based environment. That's just the way we are. We think we're expert at what we do. We feel that we're giving the most optimal, evidence-based, consistent care, despite being in a paper-based environment there. But what's interesting for me is that when a physician does make the migration to an electronic health record, a good one that allows them to get the types of data back out of their system, the tune changes a bit. And what you start to hear is, wow, I really didn't realize that I had this kind of inconsistency in my practice between my peers and myself. Using excessive laboratory or radiology testing, and whether we're talking about an inpatient or an ambulatory physician practice, there is tremendous value to be gained through aggregation, analysis, and looking for opportunities in the data that you derive from your electronic health record. So, you know, the criticism out there was, well, you know, I could do that in a paper-based environment. What's the big deal? Well, that is not easy. For those of you who operate large medical record operations, either in your practice or in your hospital, you know that culling through those records, which are illegible, ambiguous, not even sure who wrote them in many times, is labor-intensive, it's costly, and oftentimes you need to focus on one or two little things in order to find that data that you're looking for opportunity. So if you have one piece of advice that I would give to physicians who are looking to select an electronic health record is make sure that you're not just buying and implementing, but that you're actually able to derive the kind of reports in an intuitive manner out of that system that are going to give you the data that will allow you to look for opportunities, figure out interventions, and improve the consistency or the quality of the care that you and your practice members are delivering.
Excellent, excellent. Phil, have you had any experience with this?
Yes, and in fact, to build on a little of what Brian and Joseph said, our network of primary care physicians, which were on different EMRs and some were still on paper, had no way of exchanging data and didn't get a lot of information, even the groups that were on EHR, from those specialists or hospitals that weren't connected. So we actually had to find ways to get a partial health information exchange to help the practices. And once they saw the data that they never had, what was happening to their members outside their office, they could practice better, be more efficient, have higher quality. The members and patients were more satisfied, and they were able to partner with the hospital or the payers in ways that they couldn't without it. So it was very helpful.
Very good, thank you. Now we're going to take the competition round. The idea of having our colleagues go from that, Farzad was just mentioning 40% adoption from the previous level of 20%. What's it going to take? What's the inflection point? What is the transition that's going to make the difference between saying, yeah, we're still in the minority, to no, we're all in the same boat? What do you think we're going to need? We already have what we already need, or the momentum's already there, or no, it's going to take these additional pieces? Anybody?
I'll answer that. I mean, I feel like that we do have the momentum. I think the scale has tipped. I think it's inevitable and it's happening. And my message, and probably docs watching this today are already strongly considering it. And I think that's true. It's time to jump in. The water's okay. It's not just words. Once you've done it and you're on the other side and you have that electronic chart and you have the data and you're getting a report card every month or every quarter that's showing you how you practice, and there's an awareness curve, and you're better. The collegiality among the physicians is better. The patient care is better. It's a neat, fun-loving competition to do well at something and be excellent.
Yeah.
And how do we know until we know? And if you don't have the data, you don't know. So I think we're there. I think it's happening. I think the question now is how quickly. Hopefully, the faster it happens, the faster the end game of the HIE will come to fruition, where we can really put the whole care continuum together.
Excellent. Joe?
I actually think that it was going to happen no matter what. I think the incentives are spectacular, makes it a lot easier, makes it happen faster. But the fact that somebody like me would have done it 10 years ago, the fact that every other industry, every other large group has already done this, means that we would have been on the road in any event. So I don't think we have anything to worry about. I think it's inevitable.
And Bill, I think that there's another new wave that's happening that's going to help push things along. The need to reform how the care is delivered and the payment reform. Our 400 PCPs are now able to do some of the accountable care type global capitation programs that they couldn't do without the data analysis and data sharing. And that's provided our physicians with about an extra $60,000 or $70,000 a year each year, which is now making the difference beyond the one-time payments from the federal government or the state. And they're saying, oh, that's a new way of doing things. So not only is the care better, but redesigning it so that it supports the practices better.
2 points I would make, Bill. One is it's a little bit like buying your first computer back in the 80s, for those of you who did that. You had a friend maybe who had a computer, and it looked sort of cool. It had a yellow screen or a green screen, and for a few $1,000s, you could get one for yourself and type letters without using a typewriter. And so you went through this sort of decision-making process. Do I really want to spend $3,000 on a typewriter that looks a little fancy, and it was cool, it was sexy, and somehow you made the plunge, some earlier than others. And look where we are today with desktop and mobile computing devices and smartphones. There's a lot of value that is realized that does not go into the decision-making process. You make your decision based on other things, like peer pressure. Peer pressure is very strong, and when we talk about tipping point, to a large extent, it's about peer pressure. If you're in a competitive market, in an ambulatory setting, and all the practices around you are building nice websites, they've got patient portals, and they have electronic health records in their offices, and they're doing e-prescribing, that's peer pressure. And there's a little fear with that as well. Am I going to lose my patient population because I'm still handwriting prescriptions that they have to go to the pharmacy and wait for and call me back because they can't read my writing? Or am I going to jump on the bandwagon here and do what my competitor down the street is doing and electronically prescribing and creating that kind of patient satisfaction that we need? So I think it's two things. I think it's the novelty, I think it's the peer pressure, and I think we are moving in the right direction. Whether we're at the tipping point or not, I'm not sure, but we're certainly heading in the right direction.
Excellent. One of the things about this HIT world that we're going into as physicians is there's a piece to it called CDS, Clinical Decision Support. Mm-hmm. And kind of an offhand observation is that when we tell stories about decision support, our colleagues have less trouble actually understanding why we bother with all of this, because it in fact speaks to the heart of medicine about demonstrable impact on patient care and quality and outcomes and the rest. Are there any stories you guys like to tell about decision support and actual improvements or changes in care?
Well, we have noticed, and we track it year by year, month by month, the patient outcomes, and adding the decision support and best practice has every month there's about a life saved. We also look at, are we performing at the best practice, and our docs know that they could not without the extra decision support and the extra data. So the satisfaction that comes from knowing that you're practicing better and close to the best that you can is allowing us to recruit more PCPs and having the offices expand, and we're getting a lot of positive feedback.
I guess I would add to that, decision support obviously takes many forms. It could be a evidence-based set of orders for the treatment of a patient with asthma. It could be a protection for you as a prescriber for overdosing morphine. It could be a library of medications and a smart infusion pump that protects the nurse from accidentally misprogramming the pump there. It's a double-edged sword. Decision support delivered to you from a vendor, you have to be a little bit wary of, and we always caution new practices and new hospitals that are moving forward to not turn everything on, because there is a risk of over-alerting or alert fatigue, and people then overriding the types of decision support that are quite helpful. But done in a proper way, monitoring decision support, building it in a very focused and directed way to accomplish what you're trying to do, be it either evidence-based care delivery or protection from the overdose of a toxic drug, not hydrocortisone cream, can be extremely valuable. We use decision support in our organization in a variety of ways, and I'll just highlight one example, and that is in the detection of adverse events. They're using trigger data. So many of you are familiar with the IHI trigger tools, which are manual tools where you do 20 paper-based chart reviews per month looking for many, many different triggers of adverse events. One of the beauties of electronic health records is you can automate that. It's not proactive decision support necessarily. It's not something that in the course of caring for a patient, you're going to be interrupted with a suggestion that you do something differently. But it's extremely valuable in allowing you to automate the detection of adverse events in large collections. So most organizations, when there's an error from an overdose, let's say, that oftentimes results in an incident report. It's voluntary, but we know that the voluntary reporting of incidents grossly underestimates the actual number of incidents that go on in that very same category. What automated adverse event allows you to do, detection allows you to do, is to detect all those events in that area. And now you can be much better informed about how to move forward and put in preventive measures and decision support to prevent those errors from occurring.
Related to that, in our practice, we were able to, when the simvastatin recall and the 80 milligram dose came out, we were able to query our database on every patient who was on simvastatin 80 or was on combination with an amlodipine therapy, send them an email and intercept that process prior to them going to the pharmacy. And I have patient story after patient story of, they've been on 80 for a long time, so I don't know if we saved anyone's kidneys or their life, but potentially. But certainly the patient satisfaction and the feedback we got to our practice in our ability to do that, and how care for the patients felt was phenomenal, just because we sent an email with like the push of 3 buttons. So
Yeah.
And Joe, I think has one. Joe.
Okay.
Well, I was just going to say, for me, I'm a gynecologist. I don't have a lot of decision support tools. But I have to say, and I must admit, if I were a primary care physician, this would really be important to me. But in my medical record, a reminder comes up on every patient that hasn't been vaccinated for HPV who is still eligible for HPV vaccination. When I didn't have that reminder, I forgot.
There we go.
And it seems to me that if I were a primary care physician who not only had HPV on their mind, but had all these other vaccinations, this would be a really important tool for them.
Thanks, Phil.
And well, one added point to build on what Kevin and Joseph said, the comfort you get that our PCPs get knowing they're not going to forget something. It's helpful when we want to bring on new docs and recruit. They like that type of practice, and several of our practices have actually cut their malpractice insurance in half by having these systems in place, and that not only gives reassurance, but a fair amount of savings. So
I
it
should
is
have
helpful.
mentioned that too. My malpractice insurance cost has gone down because I'm using this technology.
Fantastic, fantastic. You know, if we take those percentages at face value, 40% have adopted in the country, still the majority have got to adopt if we're going to have a consistent utilization nationwide for the benefits that we've been talking about. What cautionary tales should we be providing to those of our brethren that are naive to the adoption, besides, you know, don't listen to Bria? Besides that, what should we be telling them about, I don't know, the pace of change, their involvement with implementation plans? Is there any wisdom we should be sharing there?
Well, first of all, I would say listen to Bill. In fact, I was
Just a second.
I was actually chief resident when Bill and I helped our hospital, our teaching hospital, to roll out the first EHR in the Valley. So Bill and I go back.
I was 16 years old.
Yeah, that's right. That's right. But I would say that now is probably the ideal time. The hardware has gotten faster and cheaper. The products have gotten better. There are coming online some web-based alternatives if you don't have a server in your office, and many of them meet all of the standards. So I agree with what Joseph said. Probably wise not to choose sort of one that hasn't been around or has no experience or base, but I think now is the time to get in. If you wait much longer, you'll miss the advantages and some of the positive things we've been talking about.
I'll go ahead.
Yeah.
No, go ahead.
I would say there are several issues here, and but I want to speak to one of them. And, you know, selecting the right vendor, adequate support and training, reputable product, visiting offices, as we've mentioned before. But to me, the key ingredient is physician engagement. If the physician, whether they're solo, practice, or hospital-based in a specialty, is not engaged in this effort, the likelihood of success goes down. The physician in a practice who turns everything over to the office manager and said, just take care of this and let me know when I'm going live, is likely to not do well. We see that all the time in our community when we try to recruit practices. If the physician champion is not identified early and doesn't get heavily involved with the training and the advocacy of what's going on, the project management and the timeline, then those practices oftentimes have problems. So if it was the one thing that I would say as a piece of advice for a practice, a hospital, or even for an individual provider, is get engaged early and be the person who's directing the show.
Excellent. Joe?
Well, you said some cautionary tales, so I will confess my biggest cautionary tale. I started in 2001. In 2002, I left my database open while I was upgrading another program, and I somehow corrupted my data file. I thought that I was backing up twice a day, and I was. The only thing was I was backing up everything that I had on my computer except for my database file. I had just been elected to the board of the AMA, and all I could think of was board member of the AMA loses license because of the loss of 1,000 medical records. So I have two suggestions because of that situation. One is, in this day and age, in spite of the fact that I use a server-based system, I would say to people, if you're going to do it now and you're in a small practice, by all means, find one that's either cloud-based or is hosted so that you don't have to worry about the backups. If I told you, I mean, every day in the back of my mind is, did I back up correctly yesterday? And I can tell you that even when you do have the files, and I did get the file back, but that's a long story. Even when you do have the files, when you have to restore something, it isn't something that happens instantaneously. It can take 4 or 5 days to restore your data, especially in a small system. So I would strongly recommend that people be hosted or cloud-based if they can. The other thing I would say is if you're not, then you need to back up incessantly in duplicate, and you need to monitor the fact that you're backing up and making certain that you're backing up.
Data pressures.
And as long as I have the opportunity, I'd say 2 other things that I would say is a cautionary thing. I think it's really important to achieve meaningful use, but what's more important is to have a workflow you can live with. So when you're installing this, make sure that you're comfortable with the final workflow that you're going to end up with. Because if you pick a vendor where you can't change that workflow to be something that's more comfortable for you, you're going to hate work every single day. And the last thing I would say is do it now. There's no reason to wait anymore. And the earlier you do it, the more comfortable you'll be and the happier you'll be. You can't wait for perfection. Anybody who's purchased an iPad 1, okay, knows that eventually there'll be an iPad 2. Anybody who's purchased a laptop knows that 2 years from now there'll be something that they want even more, but that's no reason not to do it now. So
Right.
I would strongly recommend getting into it now while you can. It's easy, and it's a lot easier than you think.
Thanks, Jim. Kevin?
Sure. So my cautionary tale, I'll say what Brian said because it needs to be said again, is you must have a physician champion, and you have to have physician engagement or it doesn't work. And we've just seen that across the country and in this space multiple times. The second thing is you need to invest as you're looking at your budget. There needs to be a significant portion of the budget set to training. Super user training, both at the physician level, the nurse, medical assistant level, is important. You get that money back on the back end in a major way on your speed of implementation and how quickly you can get your schedule up and running. The other thing is don't go into it without seeing some of the implementation strategies out there. Learn from all of our mistakes and all of our hard work of the people who were the early adopters. There are ways and methods to do this well now that's been well studied, and there's different things for different people. If, for instance, in your practice, if you cannot afford to see less patients on day one no matter what based on your financial constraints, there's ways to do that. You know, we had a physician who did that in our practice. They charted in the EHR 5 charts a day the first 2 weeks, and they did the rest. They dictated it and scanned it in that day, right? Put it in a progress note. The next 2 weeks they did 8. The next 2 weeks they did 12, and they refused to go down on their volume. There's lots of stories and strategies, and so to think about a real implementation plan is very important. I would caution you to not just turn it on and try to go.
Terrific. Anybody want to follow up
I
on
have
that?
one other thing I want to add there, and it's about optimization. I think across the country, we're pretty good at buying, implementing, and getting people to a basic level of use of electronic health records there. The cautionary tale there is when you're moving forward with an electronic health record, make sure that you build in a period of optimization. So after you've gone live, 2 weeks, 4 weeks, 6 weeks later, have that expert come back into your office and give you some tips and tricks about how to become an expert user and not just a basic user of your tool. You'll be a lot happier if you do that.
Okay, so I want to close out and take our time with this last one. Our profession wouldn't exist without our patients. Duh. You know, the idea that there are very specific aspects, certainly of meaningful use, but of the information technologies that we're talking about in terms of patient connection. You guys are early adopters. Are there any stories that our colleagues and our patients ought to know about the ups and downs of, and I'll tell you why in just a second, why I'm asking, of the ups and downs of the use of information technology in day-to-day practice. Had a colleague, very well respected, let's say about 7 years ago, that was terrified of the patient's ability to go into the electronic record and make comments. Not change the record, but make comments for medical legal reasons, for I don't really want to see that reasons. There was a change in a structure where we have had, we're the doctor, we tell you what to do, and then you do it. Of course, we know that's not the way it works. But the idea of in the electronic world where we're talking about patient information free and open, so my 26-year-old son in New York who asked for his record isn't told that's a HIPAA violation. True story. The idea that our patients now can have as much power of information as we can have with our information systems. Any stories about that?
Well, I don't, my patients and I have an interactive website where my patients can contact me. I would say that, and I've had it since 2001, so this is nothing new for me. I would say, first of all, messaging on the website is great when you have an EMR because I can cut and paste from the website into the patient's medical records. So anything that I said to her and anything that she said to me is in the medical record. Whereas if you do it on the telephone, you're paraphrasing what you said. The second thing is the idea that she can do it when it's convenient for her and I can respond when it's convenient for me instead of having a telephone call interrupting me in the middle of my day is a tremendous, tremendous bonus. There was a time, and I could still do this, but I don't, I thought I would charge if I saved the patient an office visit by using this messaging. So I put on the website that it would cost them $15 if I answered and saved them an office visit, and people stopped using the email rather than paying the lousy $15. And I decided it was worth $15 to me not to get the phone call. So I now do it for nothing, and it works much better. Also, they can make their appointments over the web, so that decreases the phone calls in the office, and it makes it easier for my office manager to handle those. So I think it's great. I think I would isolate the medical record from the patient. I don't think patients should enter things directly into a medical record. I can see them entering it into a personal health record and my having access to it. But I think the medical record, I'm the steward for that medical data, and I wouldn't want it complicated by having patient comments in it unless I've recorded my responses, et cetera, the way I just described.
And Bill, I think also one of the advantages is that we who have these records and have components of health information exchange get access to data from the hospital and the specialists that we wouldn't otherwise. And we do get some electronic reminders from health plans. I would just caution that you can avoid some headaches by making sure some of the information you get as suggestions from either a health plan or that aren't part of the medical record, as you said, not making them part of the medical record, particularly if there's someone else's interpretation. Or so it's good to have those extra bits of information, and when appropriate, with you as the filter, to share them with the member, and it helps their understanding, our care, and their well-being. But there are electronic communications that need to stay out of the record and are really for office operations or other reasons.
You know, the buzzword for what we're talking about here is patient engagement. Care is better when the patients are engaged, and it doesn't necessarily have to be electronic. Maybe it's just that the visiting hours are longer. or perhaps the patient's involved with rounds if they're in the hospital there. But patient engagement is facilitated with health information technology. And it's really where we need to go here. The patient that's engaged is going to have better health care and better outcomes than the patient who is not engaged. So we've got many practices in our Children's IQ Network in the region here who've adopted patient portals. And that is a huge source of satisfaction, improved quality, and even safety for the patient, because they can get on there and they can enter everything from family histories to medication histories. They can ask the questions that they may not be comfortable with or even have the time to ask their physician in their presence there. They can get their refills and not be going 30 days without a refilled medication, and even in many cases self-schedule themselves for the next available appointment there. And that's not even entering the whole realm of televisits, teleconsultations, and the actual ability to deliver and receive care without having to drive, park, and find an office and come late and have your appointment be canceled. So it's about patient engagement. I think there's some great stories out there all over the country about how patients are becoming more engaged in their care, improving their quality, reducing their costs, and really that's part of healthcare reform.
Yes, our practice has enjoyed all of the benefits that Brian just talked about. We've got almost 13,000 patients on our patient portal, and we exchange their lab data, x-ray data. They email us back and forth about questions that they would have. It allows us to not use nursing staff to have to take all those phone calls, type all those messages out, and so it saves a lot of staffing time as well. And like Joe said, it's a very accurate message that way. I think one of the things that you were alluding to is how concerned is the physician that the patient's literally looking at their medical record. And I think we should be clear. I mean, most of these portals and what we're talking about exchanging is called a continuity of care document. So what they see is the last time they were in the office, what your diagnosis was, what your instructions were, their medication list, their diagnosis list. And that can be very helpful. It engages them. They can ask questions about that list. Hey, you forgot this, or what does that mean? I didn't know that was called gout. I thought I had arthritis, et cetera. So it's that's what they see. They don't literally read the narrative of your notes. And so just so that's clear for docs who are wanting to kind of jump into the electronic health record world, that's what they see.
I just wanted to add two things. One is I worry more about what they enter than what they see. I think what they see, I mean, I've always given the patient a copy of their medical record since 2001 because it was so easy to do. So whenever they leave the office, they get a copy, and I ask them whether they want me to send a copy to their primary care doc. The second thing I wanted to say is for somebody who's a physician who also travels a lot, like me, it's a way that my patients can keep in touch with me even when I'm traveling. So it's a tremendous help that way.
So I'd like to tell my own story at the end now, because one of the things that I've had colleagues come around with is that why are you so excited about this? You know, why, you know, this don't understand why these foreign objects should show up in our exam rooms and in our offices and all of these elements now at this point in my career. And you can talk about someone that's 30 versus someone that's 60 versus someone that's 80. Doesn't matter. Let me tell you a brief story. This is from a good friend of mine. He's a physician. And his son, as he was finishing college, was found to have a number of very shocking serious medical problems. The kid, they thought he had a pneumonia, but in fact he had bilateral pulmonary emboli. As that was discovered, it was found that he had significant lower GI bleed, which was discovered to be secondary to ulcerative colitis. How many people here know that UC is associated with massive pulmonary embolism? There are no hands. One hand going up from Michigan State. Thank you, Mike. The evaluation continued. LFTs, liver function tests, were elevated. Even as the treatment of the PE and the GI bleed receded, the liver dysfunction worsened. there is an entity called primary sclerosing cholangitis, progressive scarring of the bile ducts, that, as far as anybody knows, is irreversible. And one thing after the other with this poor kid, over about 2 years, resulted in a very high MELD, M-E-L-D score for liver transplantation. And this is now a 28-year-old boy. And it was catastrophic. Even though his father was a clinician, the idea of having all of these things happening one after the other was devastating. And it was about a month gap when the plan for transplantation was firmly made at a hospital in New York City. And kind of desperate, his father goes online. We're all surrounded by Google and everything else these days. We're in an electronic world. We've been talking about all of these instruments as we go. But he sees an article from Dr. Cox in Lucile Packard Hospital in Stanford. And Dr. Cox, 15 years earlier, had a 15-year-old girl that had PSC that he treated with the antibiotic vancomycin, totally unrelated reason. He thought it was wrong, but her LFTs, which had been very elevated, within the week course of treatment became normal. And he said, must be a fluke, you know, that's it must be an interaction, so I'll stop it. They go right back up again. He tried over and over and over again, over 15 years, to take off vancomycin in this little girl with PSC, well documented. And now she's 30, and in fact, she's done fine. Has a normal life, is able to continue. So my friend says, what the hell? I'm a month away from my son having liver transplantation. And I think all of us know, even with the best of handling at that young age, what that means. And so he gives his son the vancomycin. Within 30 days, the MELD score goes below threshold for transplantation. The numbers, although not entirely normal LFTs, are pretty damn near normal. And that was 3 years ago. That friend of mine is me. That was my son. That's Billy. So without the information environment that we now are entering into as physicians, without the tools and being connected to all of this for the best care we can provide to our patients, do we believe in this, folks? Hell yeah. And in fact, the notion of saying that we need to, in fact, make those connections that we've all talked about here from evidence, from the patient, from the history, from the community, and from the rest, and make sure it all fits in. Because about 3 weeks ago, Th17 cells, which are the lymphocyte subgroup that are most related to rejection of tissue organs, have a surface configuration on the surface of those lymphocytes that is remarkably like vancomycin. So medicine isn't discovered linearly. It's discovered with serendipity. Stuff happens here and there. Things are occurring all over the planet. The idea of our accumulated knowledge is not brought to bear where it needs to be on a consistent basis. But God help us. The idea, if we can save our family and ourselves, why wouldn't we want to use these tools for every single one of our patients? So I want to thank this wonderful panel for wonderful input, and to you as well, our audience. Thank you.
Okay, I have the pleasure of introducing our next speaker. In my earlier remarks, of course, I and Drs. Bria and Bash talked a lot about transforming healthcare, the role of HIT in that transformation effort. And our next speaker, who's a fellow internist, will share not only his experiences as a practicing physician, but also some of the work that he is currently leading with and supporting at the Center for Medicare and Medicaid Innovation to support physicians with healthcare transformation. Richard Barron is currently the Group Director for Seamless Healthcare Models at the Innovation Center at CMS. But first and foremost, he's one of us. He is a practicing physician who left his practice in April of this year for this new initiative. But he practiced general internal medicine and geriatrics at Greenhouse Internist PC, which I think at the time grew all the way up to 7 physicians in the Philadelphia area. His practice was a pioneer in the comprehensive adoption of electronic health records in the small practice environment, achieving level 3 PCMH, or patient-centered medical home recognition from the National Committee on Quality Assurance in August 2008. Many of you will recognize his work from 2005 in the Annals of Internal Medicine on electronic health records just around the corner or over the cliff, which was, I thought, an outstanding example of a real-world experience, talking about the pain and the benefits and the unwillingness to return to paper, but also the wisdom and caveats for those moving forward. And actually, it was an inspiration to a paper I published the next year, which happened to use the same electronic health record technology on sort of discovering, if you will, the things that worked within our own practice that helped to explain some of the return on investment and satisfaction and quality improvements that we had seen. So Richard's work, I think, was an early example of exactly what we're trying to do with Doctors Helping Doctors. He is board certified in internal medicine and geriatrics and is one of the relatively few folks who have voluntarily recertified. He's been a true servant leader in the truest sense of the word, not only in his own practice helping to lead care transformation, but as CMO for a not-for-profit Medicaid health maintenance organization. He's been an advocate for medical education excellence as chair of the American Board of Internal Medicine's Board of Directors. He's been informing the quality improvement conversation as a member of the NCQA Standards Committee. And as recognition of his excellence in clinical medicine and leadership in the field, he has earned a couple of awards from the American College of Physicians that are rarefied, I would say. One is the chapter award from his own chapter as an ACP laureate, and I think more recently becoming a master of the American College of Physicians, which is reserved for very few, very exceptional internists and physician leaders. So without further ado, Dr. Richard Barron.
Boy, to get that introduction from one of my personal heroes, as Mike says, we use the same electronic health record product, and he is the national star, the person we all look to actually show us how to do it. I'm going to take a real risk here. David Blumenthal, I understand, came to tell audiences that when he was at Harvard and in the health policy world, it was his goal to go to audiences and say surprising and new and different things. And when he became a federal bureaucrat, it was his goal to come to audiences and never say anything surprising, new, or different. I'm now a federal bureaucrat. I'm no longer in practice, and I came with a whole bunch of slides. But I'm actually going to take the risk of not using those to try to better tell the story of the HIT transformation in practice and link that to the story of what I'm doing now at the Innovation Center and what's happening at the Innovation Center now in ways that it could relate to physicians who are thinking about adoption in, I think, very important ways. As Mike said, I really was in practice until early this year. And had a wonderful opportunity. I adopted earlier than some and later than others, Bastille Day 2004. I'm not romantic about it. I think that the article that he described in the Annals, I was very gratified. It almost never gets cited by academics reading health policy pieces, writing health policy pieces. It really doesn't. It's sort of looked at by the policy community as, well, you've seen one practice, you've seen one practice. But the Annals told me that it was downloaded over 10,000 times in the first 6 months it was out. And I can't go to a medical meeting that people don't talk about it. So I was going to mention that. I'm glad Mike did, because I think for people who are thinking about adopting, it's an unvarnished portrait of some of the challenges and, as Mike says, some of the opportunities. I think the major point I'd make to people thinking about adopting health information technology is to start with the basic recognition that we use technology to solve problems. We use technology as a tool. We use technology to help us do something that we're trying to do. And the question I think primary care people particularly need to be asking themselves as they think about adoption is, what's the problem we're trying to solve? What's the thing technology can help us with? And I think we pretty quickly get into this challenging and what has been toxic interaction between the payment system and the shape of primary care practice. So what do we get paid for in primary care practice under the existing payment system? We get paid for visits. And if you really want to be cynical about it, you could say with some accuracy that the core product of primary care practice, economically speaking, is a progress note. That the longer it is, the more you get paid. The shorter it is, the less you get paid. And the economic challenge people are trying to solve when they adopt electronic health records, many people, is how can I efficiently generate extended progress notes that will allow me to resist and pass audits with respect to the more intensive and perhaps appropriate coding I'm going to do in the fee-for-service system. And I'm not making this up. Published literature in Health Affairs in 2005 looking in the economic return on investment in the small physician practice, 51% of the return was migrating level 3 charges to level 4 and level 4 charges to level 5. So that has been a kind of principle that people are thinking about, and in my mind it explains a lot of what's worst about electronic health records out there, why all of us are getting pages and pages of garbage from our colleagues, and frankly, if we're honest about it, many of us are generating pages and pages of garbage in our own interactions, all with the target that we're after being this payment system that goes from level 1 to level 5, and we want to be sure that when those auditors from CMS come, we have written down all the things we needed to have written down, and so cut and paste and bring back last visit note become sort of core tools that we use. And I think that's deeply unfortunate. As I'll explain in a minute, it has something to do with why I took the job that I took. But in my own personal journey, another article that I was able to get out there that was genuinely a surprise to me and to all of us in our practice and had also some notoriety was something in the New England Journal in April of 2010, and it was called What's Keeping Us So Busy in Primary Care, a Snapshot from One Practice. And what we did in that article was we used the electronic health record to count something that we all knew we were doing, but we didn't realize how much we were doing. What did we do? Well, ask any doctor in practice how many visits did you do last year. Anybody can tell you. The billing system will tell you, the practice management system will tell you, the schedule you look at every day, it has 23 patients on it, it has 17 patients on it, they get crossed off. You say, oh, it was a busy day, I saw 27, it was a slow day, I saw whatever. And we're all counting RVUs, that's what we do, that's the billable unit. And yet, in primary care, we all know that there's all this other work that we're doing which we think of as hassle. Those phone calls, in our practice, emails, prescription refills, reviewing laboratory reports, many things that are not reliably connected to visits. Some of them are, some of them aren't. And using that electronic health record system that Dr. Zarukian is a national expert in, it turned out that when you have a phone call, there's a document type, phone call. When you refill a prescription, there's a document type, prescription refill. And it was very simple to ask the electronic health record to count, well, how many phone calls were there in 2008? How many prescription refills were there in 2008? And then, being a kind of math kid whose competence stopped just past algebra and before calculus, I was able to say, well, how many doctors do we have? How many days did they work? We would have a denominator of doctor days worked, and we'd have a numerator of number of visits, and then these other things that we weren't counting in the past. Prescription refills, phone calls, review of lab tests, review of consult letters, the work of primary care. What did we discover? Well, we were doing about 19.2 visits per doctor per day in our practice, which is low for family medicine, maybe low for some internal medicine practices, depends. But it's internal medicine and geriatrics, and that was the number, and it is what it is. That was, of course, the revenue-generating activity, the only thing for which we got paid. But we were doing 23.4 phone calls per doctor per day with patients. And if you ask yourself, what's the work you're doing on a phone call? You're on the phone with a patient, and a patient's asking a question. And to answer that question, almost certainly you need access to information, and you need it now. Let's look at prescription refills. We were doing 11.4 prescription refills per doctor per day. Again, unconnected to visits. If we refilled it during a visit, it didn't show up. If we refilled it outside a visit, it did. And given the way the system worked, that could have been 10 drugs, that could have been one drug. A prescription refill note was one event. So it's the low estimation of the number of drugs we were actually refilling. Ask yourself, when a patient calls and says, I need a refill on my Lipitor, my atorvastatin, what should you do when that happens? Well, probably clinically, the first thing you want to do is this patient on atorvastatin? And by the way, what's the dose? Then there's probably a reason the patient's on atorvastatin. Maybe you're trying to hit some LDL target. So maybe the next question you want to ask yourself is, well, am I hitting the LDL target? And by the way, when was the last time I knew whether I hit the LDL target or not? More information. That LDL target, what does it depend on? Well, it depends on, does this patient have diabetes? Does this patient have high blood pressure? Different targets in that situation. How do I know that? Well, if 11.4 times a day you're refilling prescriptions on patients and you need that kind of information to do it, you better have a really simple, reliable way to get that information fast, accurately, cleanly, to do that repeatedly. And what we came to realize as a result of that study in our own practice was that we ourselves had misunderstood the work of primary care. We had misunderstood our own practice. We had misunderstood the work that we did every day. We had come to believe just what the payment system told us, that the valuable thing that we did was visits, even though kind of we didn't believe that, but that was what we organized our practice around. And actually, all this other stuff that we were calling hassle was what patient care looks like in the 21st century. It's what patients expect. Why should they have to come into the office for a prescription refill or to discuss lab results, as my mother does when she sees her doctors in Albuquerque, New Mexico, other than those doctors have decided that they don't want to make themselves available for phone calls or prescription refills or to discuss labs because they don't get paid for it. And so they choose not to make themselves available for that. Why should an old lady have to come out on the ice in Philadelphia in February to do that kind of work? Is that really the kind of patient care we want to do? Is that really the kind of doctors we want to be? And I think actually most of us don't. I think actually most of us went into medicine because we wanted to give the best patient care we knew how to give, or that we could imagine ourselves giving, and every day to try to make that patient care better. And with respect to the question Dr. Bria began the last panel with, well, what do you say to colleagues when they say, why should I take this on? To me, that has an absolutely straight up, slam dunk, simple answer. It's better care for patients. End of story. It's better care for patients. When you think about all the ways we fly blind in the paper environment, all the high stakes clinical decisions we make on the phone after hours, or for that matter during the day, without having the information we need to have to make those decisions correctly. And we just accept that we don't have that information because we don't have that information because we're practicing on paper. When, in the paper world, when my partner had an important conversation with a patient in our then 4-doctor office on Tuesday afternoon, and that patient called Wednesday morning with an additional question, and my partner wasn't there, the chances that I would have access to the information that my partner had from that phone call were close to 0. That chart was somewhere between her desk and the filing system, maybe, if we were lucky, and maybe somebody could find it, but most likely in the real time that was patient practice, that would not happen. And then I would say to my staff, no wonder patients are mad at us all the time. You can call Land's End on Tuesday, order the green sweater from Debbie, call back on Wednesday, get Emily and say, you know that green sweater, actually I changed my mind, I want a blue one. She knows everything she needs to know to change that sweater from green to blue. But in healthcare, life and death matters. I didn't know what my patient said to my partner in a 4-doctor office 25 feet away from me the next day. And that's disgraceful. And Sarah Rosenbaum wrote a piece about the impact of law and medicine. And she cited a case that my wife learned about in law school. And many years ago, we had a conversation about the moral and ethical significance of this case. It's a case decided by a learned hand. It's a famous tugboat case, 1930 whatever. I don't remember the name of the case. I didn't go to law school. But the facts are something like there's a tugboat, it's towing a barge, it's in the fog. It doesn't see another boat, and it hits the other boat, and the cargo sinks. And the concern of the cargo owner is, you know, you could have had a radio. And if you had a radio, you would have known that there was another tugboat out there, and you would have missed this if you'd had a radio. And the tugboat defense was, nobody has a radio. Like, just nobody in the tugboat business has a radio. We don't have a radio, so like, of course we don't have a radio, end of story. And Learned Hand said, you know, I don't think so. I think you could have had a radio. You should have had a radio. If you had a radio, that tugboat wouldn't have, you would have known something you needed to know to avoid a problem. And I'm not trying to morph this to the tort frame or say we should do this so we don't get sued. I'm trying to talk about what the kind of doctors we want to be and the kind of practice we want to have. We don't want to be in situations where we're injuring patients, where we're making mistakes, where we're acting on less than complete information on a daily basis and say, well, you know, that's just how it is because it couldn't be another way. The fact is, it could be another way. There are radios today, and we should be using them. And so I think that the patient care piece is the most important piece. I will echo what a number of people on the previous panel said. There was nothing I did in 25 years, 30 years of practice that delighted my patients as much as when we went to email and integrated with a web portal. Nothing I did. And I'll tell 3 quick stories. One was a patient who was, as many patients were, had a personal connection, the father of somebody who was in my daughter's nursery school class, so we went back some when this happened. He got to a phase of his career where he and his wife decided to join the Peace Corps. They wind up in Bosnia at age 55 or 60. He has some medical problem in Bosnia, and he's sending me emails from Bosnia to confirm the advice that he's getting there and run it by him. And it's just the kind of doctor I wanted to be. And the question that I asked myself was not, who's paying me for this email, but how wonderful that I've set up an environment where I can be in touch with this guy even though he's in Bosnia. Another story, another patient, a professional photographer in Bolivia. He's there for an extended period of time. He gets a lesion on his penis. He goes to see a Bolivian doctor. The Bolivian doctor says we have to cut it off, not the penis, the lesion. The guy is not sure this is good advice. He takes a high quality 22 megapixel photograph of his penis, emails it to me, and says, what do you think? And I'm able to give him an answer and email it to a dermatologist friend to see that he agrees that this is probably a completely benign thing that he can ignore. And the only difference between being able to do that for all our patients and making that a regular part of practice, one is the technology and 2 is the payment system. Can we really build a model of that kind of practice? And If the payment system is all that stands in our way, well, I'll get to that in just a minute. One last story, just because I don't want them only to be exotic international travel stories. 55-year-old disabled African-American man worked for the gas company before he had a stroke, diabetes, high blood pressure. Absolutely the most vigorous user of email and diabetes control forms of anybody in our practice. We were in touch all the time by email for him to share blood glucose and get advice, and had his A1C was consistently below 7, which it wasn't before we started with this and before he joined our practice. We can do better patient care across the demographic spectrum if we do this, and if we don't, it's all about us. So let's talk about the payment system. That is my new role, and it's important to sort of talk about the how I got there and the what we do, and I think it connects pretty directly to the agenda of why we should be adopting health information technology, particularly in primary care. As Mike said, I was fortunate to be able to do some leadership on the physician side before I joined the government, ABIM work, some other places. And lots of times when I would talk to colleagues about new models of primary care, and in fact at the board we went through a process to develop, we tried to create a new specialty. We called it comprehensive care internal medicine, that would be the ambulatory side equivalent to recognizing hospitalist practice. And we had a long conversation about what are the core skills, what do we need here? And we met with stakeholders in business and insurance and specialty community and physicians. It was a wonderful process. And we came up with a set of what was remarkable was everybody agreed what they wanted from someone who was going to be their comprehensive care internal medicine doctor, their primary care doctor, the person they would rely on. Consistent set of expectations across the board for all those different stakeholders. And we wrote it up as a report, and we said the board is going to issue a credential that recognizes this set of skills. And the reaction from the community was incendiary. SGIM hated it. ACP hated it. Lots of people hated it. They said, you're solving the wrong problem. The problem is not that we don't know what to do. The problem is the payment system. We'd love to be able to do these things. If we could do them, we would do them. We can't do them, so we don't do them. So when I got a call about a year ago from Rick Gilfillan, the acting director at the Center for Medicare and Medicaid Innovation, asking me, are you ever going to leave Greenhouse Internus? Would you come down here and help us think about primary care payment systems and ACO payment systems? Frankly, it was a hard call to turn down. I loved being in practice. I miss it terribly. I had 25-year relationships with people that I did not want to end. I have a very happy marriage to my wife who tells me repeatedly, I live in Philadelphia. You can work in Baltimore if you want, but I live in Philadelphia. So it was pretty disruptive to take this position. But the reason I took this position, I want to tell you a few things about the Innovation Center and some of our programs. The most important thing to know about the Innovation Center is our goal is to test innovative models of payment and service delivery. And if those models can be shown to improve or maintain quality while decreasing total cost of care, the Secretary of Health and Human Services has authority to scale them up to the entire Medicare and Medicaid program without having to go through Congress. She can do it by administrative regulation. So the name of our game is, can we put out there payment models that lead to increased quality and decreased total cost of care? And primary care is a major focus of what we're doing. And we have out there several programs in primary care, but the thing I would tell you about all of them is we are trying to buy something other than visits. We do not want to be in the game of putting more money on the table for a level 4 than a level 5. What we are trying to buy, and what I believe is going to be what everybody's trying to buy in primary care, is a series of things. We want to see people being meaningful users of health information technology. That's an entry credential for this program in and of itself. We want to see people doing 5 core activities of primary care. One of them is routine assessment of all patients for risk, and then targeting programs for that risk. Much easier to do with standardized health information technology tools. We want to see patient engagement, the kinds of things you heard from other panels. much easier to do with health information technology tools. We want to see closing of gaps of care on a proactive basis. Don't wait for the patients to come to you who need preventive care. Don't wait for the patients to come to you who are closing gaps in diabetes care. We think of that as registry management. Okay? You can't do that without information technology, or you can, but it costs a ton of money. And we want to see care coordination across the delivery system, which today means moving information where it needs to go efficiently, comprehensively, and smoothly. And you can't do that on paper when you're sitting there with a Post-it note, kind of putting down which pages you want your assistant to photocopy before the patient goes to see the specialist. That's just no way to do business. All of the things we're looking for in comprehensive primary care are things that require information technology appropriately used to solve a different problem, the problem of excellent patient care. So my core message from my new august position at the Center for Medicare and Medicaid Innovation is to tell you that we are going to change what we pay for in healthcare and shift toward value and away from volume, and information technology is going to be a key part of that story. And if you think that primary care has no future because there's no money in it and because nobody's going into it, think again, because the fact is that people in policy positions, people in government, people in business are way more concerned about the future of primary care than almost any other aspect of the healthcare delivery system. But they're not worrying about the primary care we have now. They're worried about the primary care we need for the future. And I can guarantee you that will be an information technology enabled primary care. So good luck in your own journeys in adoption. It's a big journey, but critically important to the health of your patients, to your success as a doctor, and frankly to the country's need to be able to take care of a lot more people at a lot lower cost. So thanks for the chance to talk to you today.
So thank you very much, Richard. And to your point about being disappointed that your article in 2005 hasn't been cited by policymakers very much, I want to remind you that I was asked by the editor of the Annals to frame your article as well as another article on the NHIN. Anyone remember the NHIN? For policy circles. And my editorial was EHR's ready for prime time ? And we talked about, the noble efforts you and your practice made and what was standing in the way from a policy side of everyone else in the country doing that. Money, improving technology, connectivity, interoperability, and a reformed payment system. So your article might not have been cited many times, but your work was influential in getting us to where we are today. So we thank you for that. Before we wrap up, as I mentioned earlier, for our Doctors Helping Doctors Transform Healthcare effort, we have a number of medical and professional societies who are collaborating with us. Will Underwood of the ACP is here, and Rob Hauser of ASCO. If you'd like to briefly share any insights with the group, come on up, please.
All right, thank you, Peter. I'm Will Underwood from the American College of Physicians. And before I start off, I want to say that I and ACP are both really looking forward to supporting Doctors Helping Doctors Transform Healthcare. We think it's going to be a great effort and one that's very needed. My main job at ACP is running a program called American EHR Partners. And that's a website that we've co-developed with Scientis Technologies to help doctors with the selection, adoption, implementation, and finally the optimization of health information technology. And I just wanted to take a moment and share some of the comments that we have collected through a physician satisfaction survey that we've now run with over 12,000 physicians actually well over 12,000 physicians, and we have a number of responses that we share on the site, and it's publicly available for free. And I hope that these aren't viewed as a downer, but just wanting to explain some of the things we hear. And all of these comments start with one thing. I got this EHR, and I want to go back, but it's taking me longer to see my patients. And I'm having a hard time making my practice financially successful. Again, I got the EHR and wouldn't go back, but I've been spending the past 2 years entering data copiously into my EHR system, only to find out that I couldn't use any of it for quality reporting, and as such, I have to start over. What can I do to keep this going? When I purchased this EHR, I thought I was going to be able to share the data with the hospital right next door to me and the practice using the same EHR system, but I haven't been able to yet. ACP and I hope that Doctors for Helping Doctors can help physicians find success stories for these physicians who are going through these difficult times as they implement technology, and not forget the mission that they had when they started out on the path to implementing health IT. We are happy to be working with Doctors for Helping Doctors with this transformation process, and with helping make it a two-way street where we can help guide our physicians through their materials and provide data to help Doctors for Helping Doctors move forward. On a more positive note and a personal note, I wanted to share a story that happened last week. When I went to the doctor's office, I had 2 doctor's visits. One of those doctors asked me, well, we need to get labs for you to, before we put you on this medication. And I said, well, what labs? I just got labs drawn the other day, and I would prefer not to have to go back and do it. Well, they said, well, where did you get those labs drawn? They then went to their EHR system and pulled up the labs I had received at a different facility, and were able to make the decision on which medication they were going to put me on at that time. For my patient, who was going through a lot of different care, this was the first time that had ever happened. And I can guarantee you, I will not be changing my doctor for quite some time, since they were able to do that. And I encourage all of the doctors out there, don't forget that this is about the patients, and that you can get through it, and that there's light at the end of the tunnel. Thank you.
Thank you, Will. Rob, would you like to make some comments?
Hi, good afternoon. Yes, it is now afternoon. My name is Rob Hauser. I'm the new Senior Director for the Quality Department within ASCO, and I'm very honored to be here today to speak to you, and also to mention how happy ASCO is to support this initiative of Doctors Helping Doctors Adopt Health Information Technology. We really do feel it is critical for oncologists to begin to further adopt health information technology to not only improve their care, but begin to measure and continually improve the quality of the care that we're providing for the cancer patients. Quick story, ASCO in 2006 initiated a quality program called the Quality Oncology Practice Initiative, or COPI for short, and it really measures quality at the practice level. And when we started this in 2006, most folks in the oncology world didn't have EHRs, so we built this system as a retrospective chart review to be done twice a year. Over the last 2 years, the amount of comments we are receiving to make this an electronic system has gone up tremendously. I'm getting calls almost every day from physicians saying, when are you going to have a system that can interact with my electronic health records so I can push a button and have my COPI report in real time? So I think in the oncology arena, we're seeing a rapid uptake, which is very, very exciting. Also, one of the key initiatives that I've been tasked with is to move ASCO, or to help build a rapid learning system in oncology. And the only way that this is going to be successful is if our physicians begin to adopt, or more physicians begin to adopt the EHR and health information technology. So we are very excited to support this initiative. We believe that as we do this, the quality of oncology care at the patient level is going to go up, and we think that we'll be able to begin to aggregate all of this data and learn from each and every patient that gets treated, and be able to communicate that out to physicians. And again, you heard clinical decision support mentioned here multiple times today. Our goal is to be able to provide that real-time clinical decision support to the single doc practice in Iowa who's seeing a patient with a rare cancer that they may have never seen or only saw when they were in their residency, and to be able to see how their colleagues have managed those patients throughout the country. And then also to be able to begin to benchmark quality care throughout the country. You also heard a little bit about patient portals and patient engagement. We at ASCO believe that that's, again, a key point for health information technology adoption. I think we heard that a lot of physicians are spending a lot of time on the phone managing those either side effects or prescription refills, et cetera. With patient portals and being able to manage those toxicities, which are very, very common in oncology practices, for them to be able to manage those in a real-time manner, not only through interaction with their physician, but through knowledge and evidence-based guidelines that we created at ASCO. So again, in summary, I think what I'd like to say is, again, ASCO is very excited to support this this initiative, and we look forward to doing everything we can to help. Thank you.
Thank you, Rob and Will, and thank you to our other supporting organizations and individuals. We very much appreciate your help. To Will's point about saying something and apologizing for saying something that might have seemed a little bit negative, I want to remind everyone, the purpose of this organization is for real people working in the trenches, real doctors, to speak openly, but we would hope constructively about their experiences and help them, or rather share them, to help others who are going through similar experiences. So we very much appreciate those comments, because that will help us to make this all better. I want to, before we adjourn, take a moment to thank Janet Marchabroda, our Executive Director. Janet, without your tireless efforts, this organization would have remained a dinner conversation between three people who had one other idea that they could never have pulled together. So Janet, thank you very much. I want to thank those in the room who took the time out to join us today, our speakers and panelists, and I want to thank everyone online for taking the time to help us celebrate this inaugural event of Doctors Helping Doctors to Transform Healthcare. As Bill Bria and Mike Zarukian said, we need your help, and more importantly, your colleagues need your help. If you're interested in writing a piece, posting a blog, sharing a story, creating a podcast for us, or if we have the resources available, allowing us to videotape you, please let us know. Go to the Contact Us section of our website and send us a note. We look forward to working closely with you in the weeks and months to come through Doctors Helping Doctors Transform Healthcare. Again, thank you. All right, for those who are able to stay with us, let's adjourn.